All right, so today we are getting into a topic that comes up all the time on the front lines. Blunt thoracic trauma.
Mm-hmm.
Specifically, we're talking about rib fractures.
Yeah.
And our goal here is pretty simple. We want to refine how we think about this.
Yeah.
We need to move past some of the old dogma and get really clear on who needs to be admitted and who can safely go home.
And that shift is so important for anyone listening, for you in the emergency department or the trauma bay.
Right.
We're moving away from just counting fractures. The whole conversation is changing. It's not about how many ribs are broken anymore.
So what is it about then?
It's about physiology. It's about their pulmonary reserve. And look, can we actually control their pain enough for them to breathe properly?
For years, there was this kind of unwritten rule, a magic number of fractures that meant an automatic admission, right?
Oh, absolutely. Depending on the hospital, it was, 3 or more fractures. Sometimes even just one single fracture meant you were staying.
And what did the evidence show?
That the number is completely arbitrary. We realized we were admitting these young, healthy patients who were fine while maybe sending home an older patient with 2 fractures who was about to crash.
Okay, so if we stop counting, what are we looking at instead? You mentioned mechanism and physiology.
Mechanism gives you a hint about the energy involved, sure. But physiology is paramount. There are basically 4 things, 4 non-negotiable signs that mean you need to admit or at the very least observe very closely.
Okay, let's walk through those 4. What's number 1?
First up, anything going on in the pleural space.
So a pneumothorax or a hemothorax.
Exactly. If they have a pneumo or hemo that needs a chest tube or it's big enough that you're worried about it, they're staying, no question.
That's a clear structural problem. What about function?
That's number 2, oxygenation. It's really simple. Can they maintain their baseline oxygen saturation on room air? Or are you seeing them work harder and harder to breathe? That increasing work of breathing is a huge red flag.
Okay, so pleural space, oxygenation, what's the third?
The third is uncontrolled pain. And I want to be really specific here.
Go on.
This isn't just about a pain score. It's pain that's so bad, it's stopping them from ventilating properly. We measure this. Can they take a deep breath? Can they cough?
And how do you measure that objectively?
Incentive spirometry. It's perfect for this. If you've given them oral pain meds and they still can't hit their goal on the spirometer, that's a failure. They are on a fast track to pneumonia.
I like that. It's a functional metric, not just a number on a scale. You're measuring if the pain control is actually working.
Precisely. And the 4th factor is less about the injury itself and more about the patient's baseline.
The high-risk factors.
Yeah. Those can be the deciding factor when everything else is kind of borderline.
So let's get into those high-risk factors. Age seems to be the big one. What's the threshold we're using now?
Age is the single biggest independent predictor of mortality. We see outcomes get significantly worse for patients over 65.
Over 65.
Right. So the current thinking is that anyone over 65, even with just 1 or 2 rib fractures, they probably warrant admission for observation. Their physiological reserve is just so much lower.
Why is 65 the line? We said the fracture number isn't magic, so why is the age?
Because that's where the compensatory mechanisms really start to fail. An older patient might not even report as much pain, but they can tip into respiratory failure so much faster.
And comorbidities must play a huge role there.
A massive role. If you have someone with pre-existing chronic obstructive pulmonary disease or, congestive heart failure, a tiny contusion or moderate pain can be the thing that pushes them over the edge. You have to be aggressive with that compromised patient.
So for an elderly patient, it sounds like there's just no room for error.
That's the perfect way to put it. When you're in doubt with a patient over 65, the safest move is to admit them. An observation day is far cheaper than a catastrophe at home.
Let's shift to anatomy and imaging. For a long time, fractures of the 1st and 2nd ribs were a huge deal. It meant automatic aggressive imaging, right?
Oh yeah, that was classic trauma teaching. The theory was that it takes so much force to break those ribs that you had to have a major underlying injury, like to the aorta or great vessels.
And what are we seeing now? Does that still hold up?
The evidence is more nuanced. It does signal a high-energy mechanism, yes. But we found that if the patient is stable and they don't have other signs like a widened mediastinum, then isolated 1st or 2nd rib fractures do not automatically need a big CT angiography workup.
So we're back to what you said at the beginning. Treat the patient, not the scan, not the fracture location.
Exactly. If the patient is stable, the physical exam is reassuring. You can monitor them clinically. You don't have to jump straight to a high-dose radiation scan.
Speaking of scans, let's talk about the other thing that causes a lot of anxiety. The pulmonary contusion. That fear of the blossoming contusion.
Ugh, yes. That fear drives so much defensive medicine. And, it's true that radiographically, a contusion often looks worse at 24 hours.
So it does blossom.
It does. But here's the key. The radiographic progression does not reliably correlate with the patient getting clinically worse. You should not be treating the image.
So for a patient with a small contusion who is otherwise stable, what's the plan? Do we need to get a repeat CT just to check on it?
No. The recommendation is conservative management. If they're not hypoxic and their work of breathing is stable, you don't chase it. Getting routine repeat CT scans just to watch it is unnecessary radiation.
That's a really important point.
If the patient is breathing well, we don't care what the CT looks like.
Okay, that leads us perfectly into treatment. Management is supportive, but what are the two core pillars that prevent complications like pneumonia?
It all comes down to two things: multimodal analgesia and pulmonary hygiene. And they are completely inseparable.
One fails, the other fails.
You got it. The patient just spirals down.
So let's break down the analgesia. When your basic oral meds like acetaminophen and anti-inflammatories aren't enough, what's the gold standard?
We always start with that oral regimen, maybe with a few doses of oral opioids. But if the patient cannot take a deep, effective breath, and you've confirmed it with that spirometer, you have to escalate quickly to regional anesthesia. That is the gold standard.
So what kind of regional blocks are we talking about?
We're talking about catheter-based techniques, things like erector spinae plane blocks, paravertebral blocks, or the more traditional thoracic epidural. The erector spinae plane block, or ESP block, has become really popular. It's easier to place and has a better safety profile than an epidural.
And that effective block is what enables the second pillar, the pulmonary hygiene.
Absolutely. The block doesn't fix the lungs. It allows the patient to do the work. Pulmonary hygiene is just encouraging them to cough, to breathe deep, to use that incentive spirometer every single hour they're awake. The block makes that possible.
Let's define the most severe injury here. Flail chest. What's the precise definition, and why is that diagnosis so important for prognosis?
Okay, so a flail chest is defined when you have 3 or more consecutive ribs, and each of those ribs is fractured in at least 2 separate places.
Which creates a segment that isn't attached.
A free-floating segment, exactly. And clinically, that's what causes the paradoxical motion. The segment gets sucked in when they breathe in and pushed out when they breathe out.
And the prognosis there is much worse.
Dramatically worse. These patients have an extremely high risk of needing a ventilator, developing pneumonia. Their intensive care stay is often very long. It's a huge deal.
That high risk brings up the question of transfer. When does a patient with this kind of injury need to go to a level I or level 2 trauma center?
There are really 3 main indications for transfer. First, a confirmed flail chest. Not all of them need surgery, but they need to be at a center that can do surgical stabilization of rib fractures if it becomes necessary.
Okay. What's the second reason?
Resource limitations. Maybe the current hospital can't do the kind of advanced regional anesthesia we just talked about, like a continuous catheter block, or they don't have the intensive care resources.
And the third?
Any sign of clinical decline. If their respiratory acidosis is getting worse or their pain is just out of control despite everything you're trying, they need to be transferred immediately.
We've covered who to admit and who to transfer. Let's bring it all home. Based on everything we've discussed, who is the patient that you can safely discharge?
The safe discharge candidate is someone with stable fractures, so no flail segment. They have no pneumothorax or hemothorax. Their oxygenation is perfect on room air. And, this is critical, their pain is effectively controlled with only oral medications.
That oral medications only part seems key. It proves they can manage at home.
Precisely. They have to demonstrate, usually over a period of observation, that they can breathe deep and cough just with the pills you're sending them home with.
And, of course, you have to consider non-clinical factors, too. Their support system at home. Can they get back to the hospital if things get worse?
Absolutely. It's always a calculated risk. And I'll say it again. If there is any doubt in your mind, particularly with an elderly or frail patient, admission for observation is always the prudent choice.
This has been a fantastic reframing of how to manage these injuries. We've gone from counting bones to focusing on function and physiology. So here's a final thought for you to take away. We know patients over 65 are high risk, but how could technology, maybe wearable monitors, help us stratify that risk even better than just using age? And what other clinical markers like frailty scores or biomarkers should make us think about transferring a patient even if they seem stable right now?